1, 2,
And review, somebody female.
Oh shit, almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's
300 please.
I'll keep you on again.
Pulse check. No pulse.
no more pulse.
Yeah. Where the echo people get? And her blood pressure is also dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh. Alright guys, again. So this episode is going to be over Labetalol. Now, even though Labetalol ends in OLOL or OL, it is not strictly a beta blocker. It is a beta blocker and an alpha blocker. So in the emergency setting, we use this particular drug for like extreme hypertensive crisis. I think I've only ever seen it given like once or twice, and the systolic blood pressure was like damn near 260, 270, maybe even 280 over like Snoop Dogg, you know? So it was like stupid high over stupid high. And like it takes a while to give because you can't just slam Labetalol. And if you do, let me know because I want to be there when you do it. That way I can just kind of see like what your face is like when you realize what you just did. But yeah, Labetalol is a very, very powerful beta and alpha blocker. And the way that these pregnant women get these like crazy, crazy strong medications like magnesium and nifedipine and Labetalol and hydralazine, like it is absolutely mind-boggling to me at how much the human pregnant body can take. So yeah, this right here is a very, very potent alpha and beta blocker, and it's Labetalol. And you would be wise to pay very close attention to this episode if you're in paramedicine or looking at getting into the ICU ER setting. All right, guys. So that right there is Labetalol. Enjoy the episode.
Okay, I want you to picture this. Your patient's blood pressure is, let's say, 220, over 120.
Oh, man. Yeah, that is a terrifying number to see on the screen.
Right, and the monitor is just blaring that high-pitched, insistent alarm that immediately spikes your own cortisol levels. You know the one.
Absolutely. The one that makes you want to run in the other direction.
Exactly. And they're complaining of this massive headache, like their skull is just splitting open.
Which is a huge red flag.
A massive red flag. And if you push the wrong antihypertensive medication right in that moment, or, I mean, even if you push the right medication but the wrong way, you could just tank their pressure so fast that you completely cut off blood perfusion to their brain.
Yeah, you could cause an ischemic stroke right there. But, you know, if you do nothing, they could stroke out from the hypertension anyway. It's a total rock and a hard place.
It really is. And the drug you likely have in your hand, pulled fresh from the PX for this exact scenario, is Labetalol. So welcome to today's deep dive.
I am so glad we are talking about this today. That scenario is literally a daily reality on step-down units, ICUs, and emergency departments everywhere.
Yeah, the margin for error is just razor thin.
It is. And the sheer volume of pharmacological data you are expected to memorize to handle that moment safely is, frankly, staggering. I mean, nursing school hands you these massive encyclopedic textbook chapters on cardiovascular meds that are basically just walls of side effects and contraindications.
And molecular structures that you're never going to use at the bedside, which is exactly why we are taking a completely different approach for this deep dive.
Thank goodness.
If you are listening to this, you're probably a busy nursing student staring down a massive pharmacology exam, or, you know, maybe a new grad trying to survive your first few months on orientation.
Yeah.
Or just a clinician wanting a refresher.
Right. Someone who actually needs to know how this works in real life.
Exactly. So our mission today is to build the ultimate Pareto-optimized clinical review guide for Labetalol.
I love that. The 20/80 rule.
Yes. We are focusing strictly on that critical 20% of the information, like the nursing implications, the administration safety protocols, the real-world adverse reactions. That is going to yield 80% of your clinical success.
We are leaving the obscure, historical discovery dates behind.
Oh, absolutely.
Yeah.
Nobody cares what year it was invented when a patient's pressure is 220. We are focusing on what keeps your patient alive.
And just to set the stage for you guys listening, we are operating strictly from a comprehensive clinical source guide today. It details labetalol's pharmacokinetics, administration protocols, safety profile, all the heavy-hitting facts.
So to safely administer a medication this powerful, we can't just say, oh, it lowers blood pressure. We have to look under the hood.
Right. The mechanism of action.
Exactly. Before we talk about how to actually push this drug through an IV, what exactly is labetalol doing inside the patient's body? Because the source categorizes it as a combined selective, competitive alpha-1 blocker and a non-selective, competitive beta blocker.
Yeah, those terms, selective, non-selective, competitive, they are heavily tested on nursing exams because they literally dictate everything about how the patient is going to present clinically.
So let's map out those receptors. Like, where exactly are we sending this drug to work once it's in the bloodstream?
Okay, so we are targeting 3 distinct receptor sites in the sympathetic nervous system. First, you have the beta-1 receptors.
And those are mostly in the heart, right?
Exactly, predominantly in the cardiac tissue. Then second, you have the beta-2 receptors. Those are found in the bronchial smooth muscle in the lungs and also in the vascular smooth muscle.
Okay, so heart and lungs for the betas.
Right. And then third, you have the alpha-1 receptors. These are primarily located in the vascular smooth muscle, and they are the ones responsible for mediating vasoconstriction. They clamp the blood vessels down.
I always like to picture labetalol as this highly efficient VIP bouncer. And he's working the doors at 3 different nightclubs all at the exact same time.
Oh, that's a great analogy.
Yeah. So you have the beta-1 club, which is the heart. The bouncer stands at the door and competitively blocks the endogenous catecholamines. So, your body's natural adrenaline from getting inside and hyping up the crowd.
And the immediate result of keeping that adrenaline out of the heart is a decrease in chronotropy, which means the heart rate slows down. And a decrease in inotropy, meaning the actual force of the heart's contractions weakens.
So it's beating slower and with less force.
Exactly. That beta-1 blockade basically reduces the overall cardiac workload and decreases how much oxygen the heart muscle demands.
But our bouncer is also working the beta-2 club over in the lungs and the blood vessels.
Right. And normally, if you stimulate beta-2 receptors, it causes smooth muscle relaxation. So bronchodilation in the lungs, opening up the airways, and some vasodilation.
But labetalol is a blocker. It's stopping that from happening.
Right. It blocks that relaxing action. And finally, you have the alpha-1 club. Like we said, when alpha-1 is stimulated, vessels clamp down and constrict, driving up systemic vascular resistance.
It's like pinching a garden hose.
Exactly like that. So by blocking alpha-1, labetalol prevents that constriction. It forces the peripheral vasculature in the arms and legs to remain relaxed and dilated.
And combination is what makes it so unique, right? Because a standard beta blocker, like, say, metoprolol, is cardioselective. It's mostly just hanging out at the beta-1 club.
Right. Metoprolol is basically a 1-club bouncer. Labetalol is doing all 3.
But there is a super specific, highly testable nuance here in the source material regarding the balance of power between these blockades. Because the ratio of alpha-blocking activity to beta-blocking activity isn't just some fixed universal number.
No, it is not. And this is a huge Pareto point. It actually shifts dramatically depending on the route of administration.
Which is wild to think about.
It really is. The route fundamentally alters the drug's clinical behavior. So when labetalol is given orally, the ratio of alpha to beta blockade is 1:3.
Okay, so for every 1 unit of alpha-1 blockade, you get 3 units of beta blockade.
Correct. But the moment you bypass the gut and push it intravenously, that ratio skews heavily. It becomes 1:7.
1:7, that's a massive jump.
It is. 1 unit of alpha blockade for every 7 units of beta blockade. So you are getting a significantly more profound beta blocking effect relative to the alpha blockade when you use the IV route.
And I imagine this shift has, really profound implications for bedside hemodynamics. Why does this textbook emphasize these golden ratios so much?
Because they perfectly explain how the drug orchestrates the drop in blood pressure. The alpha-1 blocking component is what actually decreases the systemic vascular resistance. It opens up those peripheral blood vessels.
Right, lowering the resistance in the circulatory piping. But I mean, if you just drop systemic vascular resistance aggressively, like if you push a pure vasodilator,
Yeah.
the body's natural compensatory mechanism is going to freak out.
Oh, totally. The body panics. It spikes the heart rate to try and maintain cardiac output. It's called reflex tachycardia.
Which is the last thing you want in a hypertensive crisis.
Exactly. And that is precisely where the beta-1 blockade comes in to save the day. Labetalol drops the resistance via the alpha-1 blockade, but simultaneously uses its beta-1 blockade to prevent the heart from speeding up to compensate.
That is so cool. It removes the resistance and then chemically blindfolds the heart so it doesn't panic.
It's brilliant pharmacology. The result is a reduction in blood pressure without a massive reduction in resting cardiac output, and most importantly, without a significant reduction in total peripheral blood flow or cerebral circulation.
Which brings us right back to our opening scenario. This is the exact reason it's a go-to for that hypertensive emergency. You need the pressure down fast to stop end organ damage, but you cannot afford to compromise blood flow to the brain.
Right, because if you drop their cerebral perfusion pressure too rapidly, you can actually induce an ischemic stroke.
And labetalol perfectly threads that needle. It lowers the overall pressure of the system while keeping the blood flowing nicely to the brain and the extremities.
It is a highly controlled hemodynamic shift. But, understanding that mechanism is really only half the battle. To safely dose and manage this, we have to look at pharmacokinetics. We need to track its journey from the moment it enters the patient's system.
Okay, let's track it. So it's in the bloodstream. The source mentions that once it's circulating, it is approximately 50% protein bound.
Yeah. And protein binding is one of those concepts that makes nursing students' eyes glaze over, but it's super important.
Let's break it down then.
Sure. So drugs bind to plasma proteins in the blood, primarily albumin. The 50% of labetalol that binds to these proteins is essentially inert. It's trapped. It is just riding around in the bloodstream like a passenger on a bus, unable to interact with any receptors.
It can't get off the bus to do its job.
Exactly. Only the remaining 50%, what we call the free drug, is pharmacologically active and capable of crossing membranes to actually block those alpha and beta receptors.
And speaking of crossing membranes, there is a massive point in the data about its distribution. It says negligible amounts of labetalol cross the blood-brain barrier.
Which is huge for the safety profile.
Totally. Because some drugs are highly lipophilic, right? They easily dissolve in fats, so they just breeze right through that lipid-rich blood-brain barrier.
Yeah, and when they do, they often cause profound central nervous system side effects like severe lethargy, confusion, or even depression.
But because labetalol does not cross the blood-brain barrier in significant amounts, you avoid all those direct, severe CNS toxicities.
Which is a major advantage,
Yeah.
especially when you are already dealing with a neurologically vulnerable patient who has a blood pressure of 220 over 120. You don't want to muddy their neuroassessment with drug side effects.
Absolutely. Okay, so it's circulating, it's half-bound to protein, it's staying out of the brain tissue. Eventually, the body has to get rid of it.
Yeah.
And clearance mechanisms always make me nervous because this is usually where the deadly drug interactions happen.
Oh, for sure.
So the data says the liver metabolizes labetalol primarily through conjugation to glucuronide metabolites.
Say that 5 times fast.
Right. Conjugation to glucuronide metabolites sounds like pure organic chemistry torture. What does that actually mean for my patient down on the floor?
Think of it as the liver's chemical tagging system. So labetalol in its original form is somewhat lipid-soluble. That's how it gets absorbed into the body in the first place. But the kidneys, they struggle to excrete lipid-soluble substances. They just kind of reabsorb them back into the blood.
So the kidneys need help.
Yeah. The liver's job is to step in and make the drug water-soluble. It does this by physically attaching or conjugating this bulky sugar molecule called glucuronic acid right onto the labetalol molecule.
Okay, I can visualize that.
And this new structure, this glucuronide metabolite, is highly water-soluble. So now, when it floats through the kidneys, they can easily trap it in the urine and flush it straight out of the body.
That makes perfect sense. The liver acts like a processing plant, putting a tag on it that allows the kidneys to finally take out the trash.
Exactly, and it's a very efficient system. The data shows that approximately 55 to 60% of a dose appears in the urine as these conjugates, or as unchanged drug, within 24 hours.
Fast clearance. The source lists the total body clearance rate at 33 milliliters per kilogram per minute, which gives us a plasma half-life of roughly 6 to 8 hours.
So that 6 to 8 hours is your clinical window. If you give a dose, you know the patient is going to be under its influence for a huge chunk of your shift.
Right. But returning to the liver for a second, this is where we get to deliver what might be the biggest sigh of relief in this entire deep dive for nursing students.
Oh, I know what you're going to say.
Every nurse dreads memorizing the cytochrome P450 system.
It is a nightmare.
It's that massive family of liver enzymes that breaks down like the vast majority of all medications, and it is an absolute minefield of inhibitors and inducers that cause dangerous interactions.
But the clinical guide provides a definitive, beautiful statement on this. It literally lists affected cytochrome P450 isoenzymes and growth transporters as none.
0. None at all.
It's amazing.
Labetalol completely ignores the P450 system. You do not have to worry about your patient drinking a glass of grapefruit juice and suddenly inhibiting the enzyme that clears their medication, causing their labetalol levels to skyrocket and tanking their pressure.
And you don't have to panic if the provider starts them on a macrolide antibiotic or some antifungal that normally wreaks havoc on P450 pathways. Labetalol stays completely in its own lane.
It isolates itself pharmacokinetically,
Yeah.
which is incredibly valuable when you have an ICU patient on 15 different drips.
So true. But, while we get to bypass the P450 headache, we still have to navigate a massive pharmacokinetic hurdle that's related to the liver.
Yeah.
And that's the first pass effect.
Oh, right. This fundamentally explains the difference between an oral dose and an IV dose.
Exactly. So when a patient swallows a labetalol tablet, the pharmacology data states it is completely absorbed from the gastrointestinal tract.
Complete absorption. That sounds great. Like you take a pill, 100% of it gets into the blood.
Right, but it doesn't go straight to the heart or the systemic circulation.
No, it has to take a detour.
A very expensive detour. All blood flow from the gut must first pass through the portal vein, which leads directly to the liver. Think of the liver as this aggressive, greedy toll booth on the highway from the stomach to the rest of the body.
I love that.
Even though the gut absorbed 100% of the drug, the liver recognizes it and extensively metabolizes it immediately before it ever gets a chance to reach the target receptors.
The liver demands a massive tax right out of the gate. Because of this first-pass metabolism, the absolute bioavailability of oral labetalol, the actual percentage of the drug that survives the liver and makes it to the systemic circulation, is only 25%.
25%, that is a profound reduction, and it perfectly explains why oral doses are numerically so much larger than IV doses.
Yeah, you might give an IV push of, say, 20 milligrams, but the oral dose might be 200 milligrams.
Exactly. You literally have to saturate the liver's toll booth with a massive oral dose just to ensure that the 25% that survives is enough to actually lower the patient's blood pressure.
But the source does note that despite this heavy tax, the absorption is highly predictable. There's a linear relationship between oral doses ranging from 100 milligrams all the way up to 3,000 milligrams and peak plasma concentrations.
Meaning if you double the oral dose, you predictably double the systemic concentration.
Right. But there is a fascinating and highly testable quirk regarding oral absorption in food.
Oh, this is a great clinical teaching point.
Because typically clinical pharmacology teaches us that taking meds with heavy meals either delays absorption or physically blocks the drug from reaching the intestinal walls, right? It usually lowers bioavailability.
Usually, yes. But labetalol does the exact opposite. The clinical guide explicitly states that the absolute bioavailability of labetalol is increased when it is administered with food.
That is so counterintuitive. Why does that happen?
Well, the presence of food, particularly fats, alters the splanchnic blood flow, the blood flow to the gut, and it effectively overwhelms or bypasses some of that initial hepatic extraction. More of the active drug slips past the liver's toll booth when it is taken with a meal.
So the liver is distracted by the food and the drug sneaks by.
That's a great way to look at it.
But think about the nursing implication for patient education here. You're discharging a patient with a new prescription for oral labetalol. If they take it on an empty stomach on Monday morning, they get a specific therapeutic effect.
Right.
But if they take it on Tuesday, right after eating a massive, heavy, greasy dinner, their bioavailability increases. Their serum drug levels are going to spike higher, and they could experience a much more profound, potentially dangerous drop in blood pressure.
Exactly. So consistency is the key intervention here. You have to educate them to take it the exact same way regarding meals every single day.
That is such a good real-world tip. Okay, so that's the oral route. Let's contrast that with the intravenous route, which illustrates why IV administration is the go-to in acute crises.
Because when you give it IV, you are completely bypassing the GI tract and the portal vein. You avoid the liver's first-pass toll booth entirely. 100% of the drug hits the systemic circulation instantly.
And because it hits all at once, the onset of action is incredibly aggressive. The text says the maximum effect of each IV dose occurs within 5 minutes.
5 minutes. That's from administration to maximum receptor blockade and peak blood pressure reduction.
That speed is literally what saves lives in a crisis. But, as we know, it is also what makes V administration so incredibly dangerous if the bedside management is handled improperly.
Oh, absolutely. The floor reality of managing these doses is where nurses really earn their paychecks. Knowing the kinetics is useless if you don't know how to safely get the drum from the vial into the patient without causing an adverse event.
So let's dive into those administration safety protocols. Let's start with oral, since it's the more stable route.
Because it has to navigate the gut and the liver, the timeline is extended. The full antihypertensive effect of an oral dose is generally seen within 1 to 3 hours.
Right, so if you give an oral dose at 0800, you are not checking the blood pressure at 0815 expecting to see a miracle.
No, you're assessing the therapeutic response at maybe, 9:30 or 10 o'clock. It is a slow burn.
The clinical guide also dictates that decisions regarding further titration, like whether to increase the dosage, should be assessed at subsequent visits or checks approximately 12 hours post-dose.
And to reach a true steady state maximal blood pressure response, a patient actually needs 24 to 72 hours of consistent twice-daily oral dosing.
So oral management requires patience. You are slowly coaxing that pressure down over days. Intravenous management, on the other hand, that is an absolute sprint.
It's a sprint, and it comes with strict, non-negotiable safety rules. The absolute golden rule of a 5E Labetalol administration, heavily emphasized in the clinical parameters, relates to patient positioning.
Yes, you must keep patients in a supine position during IV administration.
Flat on their back. This is not a suggestion, it is a mandate.
I really want to paint a picture of why this matters so much. Because we discussed earlier how labetalol blocks alpha-1 receptors, causing massive vasodilation in the legs and arms.
Right.
Now, when a healthy person stands up, gravity naturally pulls their blood down into their legs. The body senses the drop in central pressure instantly, triggers alpha-1 receptors to constrict those leg vessels, and triggers beta-1 to speed up the heart, shooting the blood back up to the brain so they don't pass out.
That's the normal reflex, but labetalol completely paralyzes that entire reflex arc.
Exactly. So if your patient is sitting in a chair, or if they decide to stand up to use the bedside commode while you are pushing IV labetalol, gravity pulls their blood down. The vessels cannot constrict to push it back up. The heart cannot speed up to compensate. Their cerebral perfusion drops to near zero, and they will immediately lose consciousness and hit the floor.
It is terrifying to watch. The nursing protocol explicitly states you must establish the patient's ability to tolerate an upright position before permitting any ambulation whatsoever.
And continuous blood pressure monitoring is required during the administration and for a significant period after.
Okay, let's walk through the actual mechanics of a direct IV injection or an IV push. The protocol states no dilution is necessary. You can push it straight from the vial or the pre-filled syringe.
But the speed of the push is everything. How fast are we delivering this?
The guideline is highly specific. Inject slowly over 2 minutes.
2 minutes. Let's talk about what 2 minutes actually feels like at the bedside.
It feels like an eternity.
It really does. The alarms are going off. The physician is looking over your shoulder, asking for an updated pressure. Maybe the patient is restless, and you have this syringe in your hand. It is incredibly tempting to just flush the medication in over 10 or 15 seconds so you can move on to the next critical task.
If you yield to that temptation and rapid push labetalol, you are delivering a concentrated bolus of profound alpha and beta blockade directly to the heart and systemic vasculature all at once. Which means the sudden, uncompensated vasodilation, coupled with an immediate drop in cardiac inotropy, can result in a catastrophic, precipitous drop in blood pressure. You could push them into a systole or a severe hypotensive crisis that is incredibly difficult to reverse.
You literally have to physically stare at your watch or the wall clock. You push a tiny fraction of a milliliter, wait 15 seconds, push another tiny fraction, and maintain that slow, steady delivery for 120 seconds. It has to be a deliberate, methodical intervention.
And because of that 5-minute peak effect we discussed earlier, the hemodynamic documentation has to be meticulous. The protocol requires monitoring the patient's supine blood pressure immediately before the injection, again at 5 minutes after the injection, and once more at 10 minutes after the injection.
That timeline aligns perfectly with the drug's pharmacokinetic journey. You check before you push to establish your baseline. You check at 5 minutes because that is the exact moment of maximum physiological effect.
Right. You need to know how low the pressure has dropped at its absolute nadir.
And then you check again at 10 minutes to ensure the patient is stabilizing and the pressure isn't continuing to tank dangerously.
Now, there is also a highly specific mechanical warning in the source material regarding the physical equipment used for these IV pushes. It specifically addresses the use of pre-filled glass syringes.
Yes. This is such a unique, vital floor reality. You rarely see this taught in a textbook, but it happens constantly in actual practice.
It's one of those things you learn the hard way if you aren't warned.
The manufacturer explicitly warns that pre-filled glass syringes of labetalol may malfunction, break, or clog when they are connected to certain needleless lure access devices, or NLADs.
The physics of a glass syringe interacting with a plastic needleless connector create a serious risk for pneumatic pressure buildup. So the protocol requires very specific handling steps to prevent disaster.
Let's go through them. First, the external collar must remain attached to the syringe.
And here is the counterintuitive part. Before you connect it to the patient's IV line, while the tip cap is still firmly attached to the syringe, you must push the plunger rod slightly to break the friction seal of the rubber stopper inside the glass barrel.
Right. If you attempt to attach the syringe to the patient's IV line and force the plunger without first breaking that static friction seal, the amount of pressure required to move the stopper can cause a spontaneous disconnection.
The glass syringe will violently pop off the NLAD, resulting in a sudden spray and complete loss of the drug product. Or worse, the pressure can cause the glass barrel itself to shatter right in your hands.
Which is terrifying when you're dealing with a patient in crisis. So you break the seal, then you twist off the tip cap, then you securely attach it to the IV line. And the protocol mandates visual inspection of that connection before and continually during the drug administration.
You do not look away from that lure lock while you are slowly pushing the plunger over those 2 minutes.
Okay, so those protocols manage the acute IV push. But severe hypertensive emergencies often require a continuous intravenous infusion to maintain a steady drop in pressure over time.
Yeah, push might wear off, so you need the drip. When setting up a continuous infusion, the initial starting rate is generally 2 milligrams per minute.
And from there, the nurse titrates or adjusts the rate up or down strictly according to the continuous blood pressure response.
To contextualize just how profoundly effective this continuous infusion is, the clinical data provides an average response metric. In patients receiving a continuous infusion, a mean dose of 136 milligrams delivered over 2 to 3 hours resulted in an average blood pressure drop of 60 over 35 millimeters of mercury.
A drop of 60 points systolic and 35 points diastolic is a massive life-saving shift. It literally pulls a patient back from the brink of a stroke.
But a continuous infusion cannot run indefinitely. The receptors will eventually saturate, the patient will stabilize, and they need to be transitioned back to a manageable oral regimen.
And the transition protocol is vital to prevent rebound hypertension. You stop the IV infusion once a satisfactory blood pressure response is obtained. But, and this is key, you do not immediately give an oral dose.
No, the clinical guide states that you begin oral labetalol only when the supine blood pressure has started to rise again.
You wait for the IV medication to begin wearing off. If you give the oral dose while the IV is still exerting its maximum effect, the oral dose will eventually absorb, navigate the liver, and stack right on top of the IV blockade.
Leading to profound hypotension a few hours later.
Exactly. You watch the monitor, wait for the systolic pressure to drift back up slightly, which signals that the alpha and beta receptors are finally freeing up, and then you administer the oral dose.
Fun fact from the data: the baseline blood pressure before any intervention typically returns in 16 to 18 hours if no oral maintenance is started.
For the nurses actually mixing these continuous infusions in the medication room, the compatibility profile is remarkably forgiving, which is nice.
Very nice. The standard dilution protocols allow for 200 milligrams of labetalol in 160 milliliters of fluid to yield a concentration of 1 milligram per milliliter. Or you can do 200 milligrams in 250 milliliters of fluid.
Though the American Society of Health System Pharmacists, the ASHP, recommends a standardized concentration for adult continuous infusions of 5 milligrams per milliliter. mostly to minimize fluid volume overload.
And for pediatrics, the standard is either 1 or 5 milligrams per milliliter.
And regarding the diluent, labetalol plays nicely with almost everything. The source lists lactated ringers, 5% dextrose, normal saline, and nearly every combination of dextrose and half or quarter normal saline.
Once you mix it, that diluted solution is stable for 24 hours, whether you leave it at room temperature or put it in the refrigerator.
However, strict infection control and degradation protocols apply. Once the infusion has started running into the patient's IV line, you must discard any solution remaining in that premixed bag exactly at the 24-hour mark.
All right, so we have established how to push the drug safely. But pharmacology is never without risk. Even if your administration is completely flawless, the mechanism of action inherently creates a massive profile of potential adverse reactions.
We have to identify the severe clinical red flags, the absolute contraindications, and the routine side effects you will be managing on a daily basis. Let's look at the dark side of labetalol.
The clinical guide doesn't actually use a giant bold header titled contraindications, but the section detailing severe adverse reactions serves exactly that purpose. These are the catastrophic events that occur when you give labetalol to a patient whose physiology simply cannot tolerate the receptor blockade.
The cardiovascular severe reactions include myocardial infarction, AV block, cardiac arrest, bradycardia, and heart failure.
We have to trace those severe reactions back to the mechanism of action. By blocking beta-1 receptors, labetalol inherently decreases chronotropy and inotropy.
Right, heart rate and squeeze.
Exactly. So if you have a patient with an existing atrioventricular block, an AV block, their heart's electrical conduction system is already failing to transmit signals properly from the top chambers to the bottom chambers.
It's already stuttering.
Yeah. If you introduce a beta blocker, you further suppress that fragile electrical conduction, potentially causing a complete lethal heart block.
It's the exact same logic for a patient in active, uncompensated heart failure. Their heart muscle is weak, and it relies entirely on sympathetic overdrive, this constant bombardment of adrenaline, just to maintain a barely viable cardiac output.
If you give them labetalol, you block that adrenaline. You literally pull the crutches away from a failing system, and the heart simply stops pumping effectively, pushing them right into cardiogenic shock or cardiac arrest.
Okay, moving beyond the heart, the severe cardiopulmonary risks also include laryngospasm and bronchospasm, and this directly implicates the beta-2 blockade.
Remember the bouncer at the lung club. Stimulating beta-2 receptors causes the smooth muscle in the bronchioles to relax, opening the airways. This is why asthma rescue inhalers, like albuterol, are beta-2 agonists.
Right, but because labetalol is a non-selective beta blocker, it physically occupies and blocks those beta-2 receptors in the lungs.
Now, for a healthy patient, this blockade is usually asymptomatic. But for a patient with severe reactive airway disease, asthma, or COPD, their ability to breathe relies on those beta-2 receptors remaining active and responsive.
Blocking them induces profound, potentially fatal bronchoconstriction. They will wheeze, they will gasp, and they will desat very quickly.
Moving away from the heart and lungs entirely, the severe reaction profile extends into systemic toxicities. The data lists hepatotoxicity and hepatic necrosis.
Hepatic necrosis is the physical death of liver tissue. While it's rare, it is a devastating idiosyncratic reaction to the drug that requires immediate cessation of therapy.
And the immunological and hematological adverse events read like a pathologist's nightmare. The source details visual impairment, angioedema, which is that rapid, terrifying swelling of the face, tongue, and airway, and dangerous blood dyscrasias like TTP, which is thrombotic thrombocytopenic purpura, and a granulocytosis.
I always have to look up a granulocytosis.
Yeah.
It's a severe depletion of white blood cells, right?
Yes. In rare cases, the body's immune system erroneously identifies the drug or its metabolites as a massive threat and mounts an attack that basically destroys its own bone marrow production. It leaves the patient entirely defenseless against basic infections.
The text also notes the potential for a lupus-like syndrome, an autoimmune reaction triggered by the medication.
So those are the rare catastrophic red flags. You absolutely must know them, but you likely won't see them every day.
Right. What you will see every single day, the moderate side effect that is the most common culprit for patient injury on the floor, is orthostatic hypotension.
The incidence rate provided in the clinical data is massive. Orthostatic hypotension, that sudden, dangerous drop in blood pressure upon standing, occurs in 1.0% to up to 58.0% of patients.
Up to 58%. More than half the people receiving this drug will experience this. We discussed the pathophysiology of this earlier. The alpha blockade prevents the leg vessels from constricting, the beta blockade prevents the heart from speeding up, and gravity pulls the blood away from the brain.
The primary nursing intervention here is aggressive fall prevention. It goes far beyond simply telling the patient to be careful.
Oh yeah, be careful doesn't work when their brain has no oxygen.
Exactly. It involves strict bed alarms, assisting the patient to dangle their legs on the side of the bed for several minutes before attempting to stand, and continuous education about not getting up unassisted, especially in the middle of the night when the environment is dark and their coordination is already compromised.
Other moderate side effects impact the genitourinary system. Ejaculation dysfunction is reported in up to 5% of patients, and impotence or erectile dysfunction in 1 to 4%.
These are profound quality of life issues, and they frequently lead to medication noncompliance if the patient isn't educated that this is a known, expected pharmacological effect rather than some personal failing.
They'll just quietly stop taking their meds. We also must address the hepatic implications of chronic therapy. While severe hepatic necrosis is rare, elevated hepatic enzymes like AST and ALT occur in approximately 4% of patients.
Those elevated enzymes are the early warning siren for liver damage. The vital nursing implication here is routine monitoring. You cannot just put a patient on chronic labetalol and ignore their labs. You must trend their liver function tests to ensure the drug isn't quietly destroying their hepatic tissue over time.
Moving to the mild side effect profile, we see the common annoyances that still require clinical management. Nausea affects up to 19% of patients. Dizziness is reported in up to 16%, and generalized fatigue is seen in up to 10%.
The fatigue makes perfect physiological sense. I mean, you are literally blocking the body's adrenaline receptors. They are going to feel lethargic.
But there are also some bizarre, highly specific quirks listed in the data that make for incredibly difficult exam questions or confusing clinical presentations. And the most prominent one is paresthesia, specifically manifesting as scalp tingling.
Scalp tingling. It occurs in up to 7% of patients. It is a transient, harmless neurological quirk of the medication.
But imagine you are a bedside nurse, you administer a powerful cardiovascular drug, and 10 minutes later your patient hits the call bell in a total panic because their scalp is aggressively tingling.
If you don't know that as a documented benign side effect, your mind immediately jumps to a stroke or an impending anaphylactic reaction.
You might call a rapid response for no reason. Knowing the obscure side effects prevents clinical panic. The source also notes yawning and dysgeusia, which is an alteration in the perception of taste, as known quirks of the therapy.
So, summarizing the nursing management for the entire adverse reaction profile, you monitor liver enzymes to detect hepatotoxicity, you implement draconian fall precautions due to the massive risk of orthostatic hypertension, you auscultate lung sounds frequently to catch any drug-induced wheezing or bronchospasm, and you educate the patient on the benign nature of scalp tingling and the potential for sexual dysfunction to maintain compliance.
We have thoroughly explored the pharmacology for a standard adult patient. We know how to push it, what to monitor, and why the side effects happen. But nursing rarely deals with just the standard adult.
Never.
What happens when your patient is pregnant? You are no longer managing one physiology. You are managing two interconnected circulatory systems. How does a drug this powerful fit into obstetrics?
Well, hypertension during pregnancy is one of the leading causes of maternal and fetal morbidity. And labetalol is frequently utilized as a frontline intervention.
So the first pharmacokinetic question we have to answer is placental transfer.
The clinical data confirms unequivocally labetalol does cross the placenta.
The moment you hear a drug crosses the placenta, the immediate clinical concern is teratogenicity. Like, is this chemical going to cause physical malformations in the developing fetus?
The clinical guide offers a really nuanced, data-driven perspective here. Extensive experience with labetalol during human pregnancy, drawn from published interventional and observational studies, has not identified a definitive drug-associated risk for major birth defects, miscarriage, or adverse maternal or fetal outcomes.
That is a massive relief.
Yeah.
The human data doesn't point to major anatomical anomalies, but what do the animal reproductive studies show? Because they usually push the doses much higher.
They do. In animal reproduction studies, administering oral labetalol during the critical period of organogenesis at massive doses, up to 4 to 6 times the maximum recommended human dose, resulted in no observable fetal malformations.
Wow, even at those doses.
Yeah, but it is important to note that at those extreme suprapharmacological doses, Fetal resorption, which is effectively the loss of the pregnancy, was observed in both rats and rabbits.
But regarding the human data, the text includes a significant, very specific caveat about the timing of those studies, doesn't it?
Exactly. The expert consensus highlights that the vast majority of these human studies evaluated the use of intravenous labetalol after the 20th week of gestation.
Ah, so they were studying it in the second half of pregnancy, long after the foundational organs had already formed in the first trimester.
Right. Therefore, you cannot definitively point to those studies and say there is an absolute absence of risk during early first trimester pregnancy. The data just isn't robust enough for that time frame.
Furthermore, the broader medical literature contains inconsistent findings regarding the prolonged use of labetalol and the risk of intrauterine growth retardation, preterm birth, and perinatal mortality.
Which places the obstetrics team in the ultimate clinical dilemma. We have a medication that crosses the placenta, lacks definitive safety data for the first trimester, and carries inconsistent reports regarding fetal growth restriction.
So why would we ever administer it to a pregnant woman?
Because in clinical practice, you are always weighing the risks of the intervention against the risks of the untreated disease. The clinical guide explicitly outlines the devastating pathophysiology of uncontrolled maternal hypertension.
It's a nightmare scenario.
It is. Hypertension in pregnancy drastically increases the maternal risk for preeclampsia, gestational diabetes, premature delivery, and catastrophic delivery complications such as placental abruption, the necessity for an emergency cesarean section, or massive postpartum hemorrhage.
And the risks to the fetus from untreated hypertension are equally grim. The high pressure physically damages the placental blood vessels, drastically reducing the oxygen and nutrients reaching the baby. This leads to severe intrauterine growth restriction and a high risk of intrauterine fetal death.
When you balance the theoretical or inconsistent risks of the medication against the guaranteed severe life-threatening risks of uncontrolled hypertension, the clinical pathway becomes clear. Controlling the mother's blood pressure with labetalol is almost universally the safer choice.
The physiological benefits of maintaining a stable perfusion pressure far outweigh the pharmacological risks.
But this decision creates a critical scenario for the neonatal intensive care nurse. When that baby is delivered, they have been sharing a blood supply with a mother taking a powerful alpha and beta blocker.
Right. That means the neonate enters the world with labetalol actively circulating in their own tiny bloodstream.
Their endogenous receptors are being actively blocked the moment they take their first breath. The clinical guide mandates strict monitoring protocols for neonates born to mothers on labetalol. You must actively assess them for hypotension, bradycardia, hypoglycemia, and respiratory depression.
Let's break down the pathophysiology of those neonatal symptoms. Hypotension and bradycardia are direct, predictable results of the alpha-1 and beta-1 blockade. The baby's blood vessels can't constrict and their heart can't speed up.
And respiratory depression correlates directly to the non-selective beta-2 blockade in their immature lungs.
But hypoglycemia, low blood sugar, that requires a deeper understanding of beta receptors. Why does blocking a cardiovascular receptor cause low blood sugar?
Because beta receptors are integral to the body's metabolic pathways. Stimulating beta receptors triggers glycogenolysis, which is the breakdown of stored glycogen in the liver into usable glucose. By blocking those receptors with labetalol, you inhibit the neonate's ability to mobilize their own glucose stores. Furthermore, beta blockers notoriously mask the classic physiological signs of hypoglycemia, like tachycardia and tremors.
That is so dangerous. You cannot rely on the baby looking jittery or having a fast heart rate to tell you their blood sugar is crashing. You have to aggressively physically monitor their capillary blood glucose levels because the medication is hiding the alarm bells while simultaneously preventing them from fixing the low sugar themselves.
Moving past the immediate delivery, we must address the postpartum period and lactation. A mother needs to control her blood pressure, but she also wants to breastfeed.
The pharmacological data states that small amounts of labetalol do actively cross into human breast milk. Specifically, it is estimated that approximately 0.004% of the maternal dose is excreted in the milk.
That is a fraction of a fraction. The text acknowledges there is no robust data regarding the specific effects of this minute amount on the breastfed infant, nor is there data on whether labetalol impacts milk production itself.
However, based on the incredibly low concentration, previous recommendations from the American Academy of Pediatrics, the AAP, classified labetalol as generally compatible with breastfeeding.
For a healthy, full-term infant, that 0.004% is easily processed by their liver and kidneys without causing systemic blockade.
But there is a vital clinical exception explicitly noted in the guide For mothers of premature infants, alternative antihypertensive agents may be preferred.
A premature infant has profoundly immature hepatic and renal systems. Their liver cannot process even microscopic amounts of a drug efficiently, meaning that 0.004% could theoretically accumulate in their system over days of feeding, eventually causing bradycardia or hypertension.
The guide suggests that propranolol, another beta blocker with a different pharmacokinetic profile, may be a potential alternative in this highly specific scenario, as it is also considered compatible by previous AAP guidelines.
We have journeyed all the way from the molecular structure of competitive receptor blockade through hepatic metabolism, IV push mechanics, and into the neonatal nursery. To fulfill our promise of a Pareto-optimized review, we need to distill this massive volume of information into the absolute highest yield clinical takeaways.
Yes, let's bring it all home. Here is your core 20% that drives 80% of your bedside success. Mechanism of action. Labetalol is a combined selective alpha-1 and non-selective beta blocker. The ratio shifts based on the route 1 to 3 for oral, 1 to 7 for intravenous.
Pharmacokinetics. It bypasses the P450 system entirely, meaning zero cytochrome interactions. But it suffers heavy first-pass metabolism orally, which is strangely improved by taking it with food.
Safety and side effects. The most prevalent risk is orthostatic hypotension, affecting up to 58% of patients. You must assess for severe reactions like hepatotoxicity, AV blocks, and bronchospasm due to the beta-2 blockade.
Administration. You must keep the patient strictly supine during IV administration. When using pre-filled glass syringes, leave the collar on, push the plunger slightly to break the friction seal before twisting off the cap, and inspect the luer lock constantly to prevent shattering or drug loss.
Push direct IV doses painfully slowly over 2 full minutes, checking the supine blood pressure before, at 5 minutes for the peak effect, and at 10 minutes.
Special populations. It crosses the placenta, but treating the mother's severe hypertension generally outweighs the fetal risks. However, you must meticulously monitor the newborn for bradycardia, hypotension, respiratory depression, and masked hypoglycemia.
That is the foundation you need to safely handle this medication in a crisis. But before we wrap up, I want to leave you with a conceptual thought to mull over regarding how we actually practice medicine. We spent this entire deep dive analyzing how labetalol blocks alpha-1 receptors to force the blood vessels open, while simultaneously blocking beta-1 receptors to prevent the heart from speeding up.
It creates an artificial, perfectly orchestrated reduction in systemic pressure.
But consider the profound implications of that mechanism. If a person suffers massive trauma and loses a liter of blood, their blood pressure plummets. The human body immediately interprets any sudden drop in blood pressure as an existential threat. It triggers a massive, desperate, sympathetic, reflex-dumping adrenaline into the system to clamp the vessels shut and whip the heart into a frenzy to save the brain.
That is the body's ultimate hardwired survival mechanism.
Labetalol completely neutralizes that survival mechanism. It drastically lowers the pressure in the system and then chemically blindfolds the body's internal alarm system so it doesn't fight back.
Yeah.
It doesn't just lower blood pressure. I mean, it fundamentally hacks the body's compensatory failsafes.
It forces you to wonder how much of modern advanced pharmacology isn't about healing a disease, but rather about brilliantly tricking the human body into accepting a physiological state it was evolutionarily designed to resist.
We were essentially overriding millions of years of evolutionary programming with a 2-minute IV push. Think about the sheer power of that reality the next time you are slowly pressing the plunger on a glass syringe. Thank you for joining us on this deep dive. Take a deep breath, review your notes, and go conquer your exams and your clinical shifts. You're ready for this.